Today we're going to talk about the anti-arrhythmic drugs. I hope I'm pronouncing this correct. So we're going to start with a story or a case study. This is a 69-year-old patient with 1 month history of palpitations, intermittent shortness of breath and fatigue. She also has a history of hypertension, and after the ECG, they identified that she has atrial fibrillation and a heart rate of 122 beats per minute. Also, left ventricle hypertrophy. That's an important one. Note it very carefully. Then, to take home, she got some warfarin and a beta blocker. But after 1 month, our patient is back and she still has palpitations and she's complaining of fatigue. So another ECG is performed and they diagnosed atrial fibrillations again with a heartbeat a little bit less than the first time she came to visit and also a low ventricular ejection fraction. So the question here is, should we start this patient on anti-arrhythmic drugs? And if we do, what class of drug would you prefer? We'll get to the answer in the end of the video. Here is a summary of all the treatment options that we are going to discuss today. So there are 4 classes of antiarrhythmic drugs. And the first one gets subdivided into class 1A, 1B and 1C. The mechanism of action for these drugs is that they are going to target our ion channels. So we're going to look at sodium channel blockers, beta receptor blockers, calcium channel blockers and potassium channel blockers. We did discuss this figure in the video about congestive heart failure, but I just quickly want to summarize it again. Phase 0 is called the fast upstroke or the depolarization. And here basically what happens is that sodium enters the cell very quickly. And this leads us to phase 1 where we get partial repolarization, and here the sodium channels close. Phase 2 is where we reach a plateau. And this happens when the calcium enters the cell, and when there's enough calcium inside of the cell, the calcium channels is going to close, which is going to lead us to phase 3, which is repolarization. Here we see a loss of potassium ions, and the potassium channels close slowly. Then at phase 4, the action potential is going back to the threshold, ready for the next stimuli. It is still important to understand how an action potential is generated in the heart, because this is again the target areas for the drugs that we are going to discuss today. So what I didn't mention in the video about congestive heart failure is the refractory periods. The absolute refractory period happens in around about this area. So it's larger than the relative refractory period, and it happens before the relative. The absolute refractory period is when the membrane can't respond at all to any external stimuli because the sodium channels are either already opened or closed and inactivated. The relative refractory period is when the membrane won't respond to a second stimuli for some time after an action potential begun, although it will respond to a stronger than normal stimuli and then another action potential will begin. The action potential of a ventricular contractile cell lasts up to 300 milliseconds, about 30 times as long as the action potential of a skeletal muscle cell. Now let's focus on the phases the drugs are going to target. So phase 0, group 1A, is going to target here. And this is going to slow down depolarization. As I mentioned previously, depolarization happens in phase 0 and it's this fast upstroke situation. It's also going to prolong the action potential or slow the conduction. Then phase 3, group 1B, it's going to shorten the repolarization, that's in this case, or it's going to decrease the duration of the action potential, or group 3 is going to prolong the repolarization. Then in phase 4, group 4 is going to slow spontaneous depolarization and also slows the conduction, but only in the tissues dependent on a calcium influx, for example the AV nodes in the heart. Alright, so here is a summary of the different types of arrhythmia that can occur and what drugs will be the most appropriate to treat that type of arrhythmia. Alright, so before we start, let's quickly look where's the atrium and where's the ventricle again. So this is a picture of the heart with its 4 heart chambers. And this arrow points to the right atrium. Just opposite it you will find the left atrium. So it's the upper chamber. And then just beneath it, the ventricles. The clinical response of atrial flutter is going to be 100 to 150 beats per minute. And the heartbeats will be irregular. Appropriate drugs to treat such a situation will be propranolol and verapamil. At AFib, we can also include low doses of anticoagulants, which can reduce the risk of stroke, and also propranolol can be added. During atrial fibrillation, beta blockers are your drug of choice because it helps with that fast heart rate, which is one of the most disturbing symptoms. Supraventricular tachycardia, we're going to use propranolol, verapamil, digoxin or adenosine. Alright, ventricular tachycardia, this is usually acute, so you're going to treat it with Lido Cane, which come in an IV form. That's also an emergency situation. And this is a common cause of death in patients who had a recent myocardial infarction, because this tachycardia can develop into a ventricular fibrillation. And then to treat a ventricular fibrillation, we're going to look at epinephrine, also an emergency drug. Let's look at the 4 causes of arrhythmias. Number 1, a drug that has an effect on the automaticity of the heart. The drugs can either suppress the automaticity or raise the threshold of discharge to a less negative voltage. Then, drugs can have effects on conduction, and it can cause abnormal conduction. So it can slow down the conduction, or it can increase the refractory period. Then, abnormal automaticity. So here, the SA note sets the normal pace. If other cardiac sites increases their automaticity, they can generate a possible competing stimuli. The stimuli is competing with pacemaker cells. Also, when you have damaged cells due to hypoxia, a decrease in oxygen, or a potassium imbalance, it can cause an abnormal automaticity. Number 4 is going to be abnormal impulse conduction. So here we are looking at a Purkinje fiber with its 2 pathways, and this is all situated in a ventricular muscle. So what usually happens is an impulse will come and travel through both pathways. But in our scenario here, we've got a block in the one pathway. So this is due to myocardial infarction that causes an injury in this pathway. So as soon as the first impulse hits the block, it's gonna make a U-turn, return to the crossing, and take the other road. This leads to re-excitation of the muscle, which in return leads to premature contraction or a sustained arrhythmia. The first class we're going to look at is Lido Cane, and this drug is administered IV. So it's going to be reserved for emergency cases. But important to know is that this class of drugs are use dependent. So it binds more rapidly to an open or an inactivated sodium channel. So the cells in the body that presents with tachycardia will be the sites where these drugs will bind to. So these drugs only blocks the cells that are discharging at abnormal frequencies, and they will not bother with cells that has normal frequencies, which is quite a good thing. So this is definitely the drug of choice in an emergency treatment, where cardiac arrhythmias, especially ventricular arrhythmias, occur due to myocardial ischemia after a heart attack. But it's also a local anesthetic. So if the name looks familiar to you, that's why. It focuses on shortening the repolarization in phase 3 and also decreasing the duration of the action potential. Some common side effects include slurred speech, drowsiness, paresthesia, confusion, and convulsions, and most of them are central nervous system side effects. Alright, so let's move on to the second class, which is going to be the beta adrenergic blockers. For example, propranolol, very known to all of us. The adult dosages for these drugs is going to be a maximum of 160 mg a day. When initiating the patient on this therapy, you want the dose to be slowly titrated upwards. It's kind of good if it's a quite frequently used drug to know the trade names. It just helps you to communicate with your patients more effectively. And then the mechanism of action. It decreases the depolarization, the automaticity, the heart rate and the heart contraction, and also mortality rate, which is a big plus. Now we're going to discuss Blue Man syndrome. Amiodarone. So if there's one thing that I want to accomplish today, is that you will remember this. Amiodarone causes Blue Man syndrome. So let's pause to give this Blue Man a moment to sink into our brains. Thank you very much. Common trade names of amiodarone is going to be Aricor, Hexarone, Cordarone. The mechanism of action is that it blocks the potassium channels and it also causes a prolongation in the action potential. But it's also very dangerous because it can induce arrhythmias. And then, it's structurally related to thyroxine. Thus, as you can guess, some of your common side effects will include thyroid issues. Also, the reason for this Blue Man syndrome appearing is because of iodine ions that gets accumulated under the skin, and this causes that blue discoloration. So the half-life is up to 2 weeks, which is quite long, and it also takes up to 6 weeks after the initiation of the therapy to see therapeutic effect. The adult dosage is usually 200 mg daily, but it can go as high as 200 mg 3 times a day, but usually then not for long periods. If a drug has such a long half-life, they usually start with a high dose, frequent intervals, and slowly tapering it down until you get a maintenance dose. The side effects include pulmonary fibrosis, which also means scarring of the lung tissue, and ataxia. Dizziness, neuropathy. Also, it causes liver toxicity. It has an influence on your thyroid. It can cause muscle weakness and also photosensitivity. Let's move on to class 4, the calcium channel blockers. And here is 2 main role plays. It's going to be verapamil with a maximum daily dose of 480 per day, and diltiazem, which is going to be 360 milligrams a day. And they can both be given in quite frequent intervals. For example, diltiazem can be given 6 to 8 hourly, where verapamil can be given 8 hourly. So the mechanism of action. The drug slows down the inward current of calcium and thus prevents contraction. It slows down conduction and also prolongs the refractory period. Also, it only binds to open or depolarized channels to prevent repolarization. Thus, this drug will work best if your patient are in a state of tachycardia, because in a normal heart cell, the calcium channels will be too quickly repolarized, and thus the drug will move away or dissociate from that target site. These drugs also decrease atrial flutter and fibrillation. Side effects include a decrease in blood pressure and a decrease in cardiac function. So the 2 last drugs to discuss in this video is going to be digoxin and adenosine. Digoxin, not very often given due to the side effects. It can cause an arrhythmia and it can cause tachycardia, so it's quite a difficult drug to manage. And then adenosine is given IV, very short half-life, and it also decreases the automaticity of the heart, decreases the conduction of the heart, and increases hypertension. let's get back to the case study. Have you figured out the answer yet? I thought so. So let's work on it together. So the symptoms that we see here, palpitations and fatigue, can be due to an unsteady cardiac rhythm. So we want to maintain a steady cardiac rhythm. So if you look at this slide, we said that the patient was diagnosed with atrial fibrillation. So the recommended drugs is propranolol and anticoagulant, which is both already given to the patient. But they also mentioned that the patient has hypertension. So I'm thinking, let's exclude verapamil from the picture, because if you combine it with another antihypertensive drug, you're going to get too low blood pressure. Also, this patient has a low ejection fraction. So digoxin isn't going to work because it's contraindicated in patients with hypertrophic obstructive cardiomyopathy. So our only option that's remaining is going to be amiodarone. I hope that you found this video helpful and insightful and that it will add value to your life, and please leave me some suggestions or questions in the comments below.